their work and then what their vision is. We're going to combine them. And so we're going to start with a lightning round from some of our researchers, and then we're going to do a panel discussion from some of our community participants. And then we're going to break out into tables and innovate, which is really exciting. So I'm going to invite Danielle Crookes, who's our first speaker. Dr. Crookes is the assistant professor of the Department of Health Sciences in the Department of Sociology and Anthropology here at Northeastern.
Thank you. Everyone can hear me okay?
Yes.
Okay, perfect. Slide advance, or are we just doing this? Perfect, so lightning talk means I gotta start my phone here. All right, so thank you so much. Today I will be talking just briefly about sociopolitical drivers of immigrants' health in the United States. So when we think about immigrants in the United States, they face a complex sociopolitical environment, and I'm really talking about the policy environment. So they face policies at the federal level, so we make DACA. In 2020, we were talking about the public charge rule. At the state level, different states have different allowances that allow undocumented or newly arrived immigrants to access or not access healthcare, or in Massachusetts, for example, to not access driver's licenses, although that just passed in the state Senate yesterday. And then as well as the county level. So we've heard more information about sanctuary policies in sanctuary cities at the county level. And so this is complex. Living as an undocumented, mixed status, new immigrant refugee in this country, depending on where you are and who's in charge to determine how things go in a day-to-day life. But exclusionary immigrant policies, government policies are form of structural xenophobia and racism. So these policies impact who can access education, free in-state tuition or scholarship, E-Verify laws, so who can work and in what capacity, who can access healthcare, public healthcare provided either at the federal or state level, and then they reapply and enforce interpersonal structural xenophobia and racism and how people are treated in that capacity. And so colleagues of mine and I conducted 2 systematic reviews. These are a thorough review of the literature to identify how are these policies impacting health. So we did 2 systematic reviews. We reviewed over 2,000 different papers published over the last 35 years or so, where we've really seen an uptick in these immigrant policies at multiple levels of government. And we found 28 eligible studies that were looking at mental health outcomes or physical health outcomes. We're excluding like behavioral things or access to care. And what we found is that 3 main outcomes were identified across all of these studies, whether they were studying federal studies or local federal policies or local policies. People were looking at self-rated health, mostly birth outcomes, and mental health, thinking depression, sadness. And across many studies, though not universally so, we saw that exclusionary policies were associated with worse health outcomes, and inclusive policies, policies that welcomed immigrants or supported them with at least their access, were associated with better health outcomes. And so what does that mean for me in the future? Currently, I'm conducting a project looking at county level sanctuary policies and their impact on receipt of cardiovascular care. So other studies have shown that things like sanctuary policies and driver's licenses, they allow immigrants to get better health care for their children. Does that apply to adults as well? Are sanctuary policies a potential solution? And then I'm curious to hear from you actually. What are the opportunities here in Boston and Massachusetts? I'm a new professor here. I'm a New Yorker by way of Georgia coming to here. And so Massachusetts policy environment is really complex. We've got exclusionary policies in place and inclusive policies in place. And so what issues are pressing here in the community? And how can this kind of research, how can I make that more accessible and useful to the community? So thank you so much for your time.
Danielle, and now it's my pleasure to introduce a colleague from Boston Public Health Commission. Danielle Dooley is going to talk about the votes identifying factors impacting racial differences in substance use disorder treatment access.
Okay, well, I'm here to talk about the Boston Overdose Linkage to Treatment Study, BOLTS. It's a collaborative study. It's qualitative, and it's examining factors contributing to racial ethnic inequities, access to treatment for people who have recently experienced an opioid overdose. So I can start out sharing that BOLTS, it was motivated by a study that we'd done previously. Hold on a second. We started out with a study that quantified different access to treatment based upon race in Boston. What we found was with a cohort of folks who had overdosed recently and shown at the hospital that essentially 30 days after that overdose at the hospital, we had lower rates of accessing treatment among our Black and Latinx residents compared to our white residents. That was the initial study in 2018, 2019. So this is a follow-up. Bolts is a follow-up study, it's a qualitative study where we're looking to try to figure out what factors influenced by accessing or not. Well, okay, so we're a collaborative actually among 4 institutions of the Boston Public Health Commission, Institute for Community Health, Boston Medical Center, and the School of Public Health as well. So it's academia, the healthcare settings, community health, and the city. Original Bolt's research questions. What are the barriers and facilitators to accessing substance use disorder? And what factors contribute to racial inequities in receipt of substance use disorder treatment? And then how can Boston systems address barriers to improve access to treatment and improve health equity? Both we had we interviewed qualitative interviews with 59 Boston residents. We had, I believe, 20 white residents, 20 Black residents, I believe 19 Latinx, who had recently survived an opioid overdose. We also had 28 key informants from a range of sectors who have professional or community leadership roles. This all the way from policymakers down to folks who are doing street outreach. Just to give a sense, we're now at the point of actually doing our analyses for these. And I don't have results per se to share at this time, but these are recently submitted abstracts for APHA, which basically gives a sense of some different areas of analysis that are coming from the qualitative study. So first, we've got workforce considerations for improving racial equity in substance use disorder treatment. So that includes considerations of staff with lived experience and need for respect from staff, and then how we implement that. We've got another analysis that looks at factors influencing readiness to engage in substance use treatment among opioid overdose survivors. And readiness, some of the high level findings there, we're seeing that that mental energy and being in the right frame of mind to engage treatment is very important. And then there are factors that contribute to that. In particular, having stable housing is very necessary to be then in a position ready to engage treatment for many individuals. We also have one on reasons for initiating continuing drug use. And here we're finding that initiation and continuing drug use, what's being elevated there are mental health issues, mental health history, trauma history, and factors related there. And then additionally, we have one that's going on, an analysis looking at the triple stigma of racism, addiction, and homelessness. So here, why is this study important? That these findings can help guide SUD treatment practice. For example, help inform how we're building our staffing models and hiring processes, training interventions, trauma-informed care, and then highlight opportunities for policy and systems level changes to improve racial equity in addiction treatment and services.
Thank you. Next, we're going to have Collette Ncube, Assistant Professor of Epidemiology at Boston University, who's going to tell us about a systems science perspective on racial ethnic disparities in maternal and infant health outcomes.
Good afternoon, everyone. Again, my name is Collette Ncube. I'll be talking about system science perspective on racial ethnic disparities. Is that better? Ah, nice, thank you. A system science perspective on racial ethnic disparities in maternal and infant health outcomes. Okay, so preterm birth is the birth of a child before 37 complete weeks of gestation. And what we know is that infants that are born preterm are at high risk of infant mortality. And then among those who survive, they're at higher risk for various morbidities throughout the life course. So it is a goal to reduce the rates of preterm birth in general. And these are trends of preterm birth rates in the state of Massachusetts since 1975. So what we see is that generally from about the early 80s to about the mid to late 2000s, that preterm birth rates have increased. And that since then, generally, they've been on a downward trajectory. The goal of the Healthy People, right now, Healthy People 2030, is that preterm birth rates are less than 9.4% or so. And in general, Massachusetts has managed to have relatively low rates of preterm birth compared to some other states, but we still have a lot of work to do, primarily because a lot of not all our racial and ethnic groups have been able to maintain a preterm birth rate lower than that, but also because compared to other wealthy nations, the US has much higher rates of preterm birth even overall. And so when we look at rates of preterm birth rate by various racial and ethnic groups, what we see is that that trend that we just saw primarily mirrors the rate among white non-Hispanic individuals in the state, and that trends among other racial and ethnic groups are not the same. So we see here, for example, that rates of preterm birth among Asian and Pacific Islanders have generally been on an upward trend, that rates of preterm birth are consistently higher among non-Hispanic Black individuals, and that there seems to be evidence of an increase in preterm birth rates in that group as well as among Hispanics as well. So I think it's important to understand what these drivers are for all racial and ethnic groups. So as I mentioned before, this is a visual representation of the goals of the Healthy People 2030. And that nationwide as well, there seems to be evidence that we are on, at least in the last few years, an upward trajectory for preterm birth rates. And so that is obviously not the goal, right? So we're not moving in the right direction with regards to preterm birth rates nationally, and in some cases in the state as well. So one of the perspectives that we might take is maybe thinking of this as a systems problem, taking a systems perspective to understanding the problem of preterm birth rates and various other maternal and infant health outcomes in the state. So when we take a systems perspective, we think of not just the event, which may be more preterm birth rates in a particular health system, but also considering the trend, which I just presented to you so that you understand the fuller picture, what has been going on over time, not simply in the last year or two, for example. And then when we think about the trend, then we have to factor in, think about what structure has shaped that trend. What has gone on, what has happened over time in the physical structures, the socioeconomic structures, various organizations, the relationships between various organizations in the state, and then also to think about our mental models, what are our beliefs, our values that have largely shaped the structure that we see, in this case, in the state of Massachusetts. And using a systems science perspective, and specifically the methodology of system dynamics, which I'm using in some of my work more recently, it helps us increase our understanding of the issue, so preterm birth rate changes over time, as well as the key drivers of those changes, to think about strategies by being able to compare the effectiveness of various potential and current interventions, be able to use those results to inform policies, answering questions about maybe why certain interventions have had unintended consequences, or maybe even had the outcome we expected or hoped for, and to also use those data to then predict what might happen down the road. For example, are we on track for Healthy People 2030 or 2040 goals? So this is just a visual as I wrap up of where we are and some of the work that we're engaged in. Stage one is defining the problem, right? So I presented part of that today, engaging a few stakeholders, but that's setting us up for stage two, where we're hoping to engage various stakeholders in the state to talk about this problem, to understand the issue in a more deeper way, to think about those structures. And then going into stages 3 and 4, where we hope to build a qualitative and actual model where we can therefore better understand the system, test interventions on it, and then going into stage 5 to be able to make policy recommendations based on the findings of that work. Thank you very much.
Yeah. Thank you so much. Our last lightning speaker is Tiana Young, Program Director for Northeastern University Public Health Evaluation Lab, and she's going to be talking to us about social connections and well-being among older adults living with HIV during the COVID-19 pandemic.
First, okay. Hi, everyone. Can you hear me in the back? In the chat, please. Oh, a thumbs up. Awesome. So thank you. Going to talk about one of our ongoing New Pell projects. So once again, New Pell is our public evaluation lab. Going to be talking about social connections and well-being among older adults living with HIV during this continued COVID-19 pandemic. So a quick overview of the study, essentially what we did. So it is, because we're right now in phase 1, a community-based participatory researcher, CBPR, qualitative study in the greater Boston area. We were able to actually complete phase 1 of this study due to our awesome multi-generational team. So multi-generational teams meaning we have our students who are undergraduates, grad students, doc students, junior and senior faculty. We were able to awesomely partner with 2 groups here that are locally based, Healing Our Community Collaborative, or known as HOC, and Victory Programs Boston Living Center. So HOC is a nonprofit or organization that supports women living with HIV, while Victory Programs Boston Living Center also is a nonprofit organization, but they support individuals and the families living and or affected by HIV. We were able to conduct 22 virtual interviews via Zoom with HOC and BLC participants, and the participants for eligibility to be part of the study had to be at least 50 years of age. We wanted to understand their perceptions of social connections and well-being during this COVID-19 pandemic. What we found from our phase 1, from the rich data, the qualitative data, that a lot of folks have compromised mental health, high levels of feeling isolated, experiencing depression, lack of social structure, and social structure meaning that a lot of our participants would say, you know, I knew what I wanted to do each and every day because I signed up for different programs, I had my schedule set, but then now with a lot of the programs changing, their day-to-day was just really unpredictable, and that increased their level of stress. Phone calls, this was something that was interesting that we found became a very popular form of communication. Participants shared with us that it was actually nice to just pick up the phone and call and then have that way of communicating and connecting with folks. We did notice a difference from folks that were older women living with HIV versus older men with HIV in terms of their social network structures. We found that older women with HIV reported family and friends, like they had a really strong social structure of family and friends compared to older men with HIV that shared primarily of acquaintances. Also, another key finding that we found was the HOC participants actually shared with us that they had little to no social isolation experiences, which that was something that really stood out to us as, you know, as a protective factor that we may want to look into further, because they shared that they actually had a really strong existing support system, and that actually helped them navigate through the COVID-19 pandemic. So importance of this work and looking ahead, significance. We're contributing to the growing research and work in order to support older adults living with HIV. Something that, especially since we're doing CBPR work, we actually want to show in some way capacity and support communities right then and there. What are the practical applications? So from our findings, we were able to show that with HOC and BLC, and that informs their upcoming programs to identify what are the areas of support that they want to build out more in, or check out different platforms to increase engagement among participants. So what's next? Our findings give implication for advancing the understanding of additional protective factors for improving well-being among older adults living with HIV, especially in their responses to unexpected public health emergencies. And we're actually now, since phase 1 has completed, we're going into phase 2 of our study, which is we're going to be co-designing with HOC and BLC participants to create an intervention that they can actually then take on and move forward. So hearing from the participants, and it's driven by the participants. So looking forward to sharing that phase once that's completed, but that'll be happening this summer. Thank you.
So that completes our lightning round. So we heard about social connections with HIV. We've heard about substance use disorder. We've heard about the challenges with preterm birth, and also our immigrant health. So I'm going to invite our our lightning round panelists to find a table, and after the community, we hear from the community representatives, You're gonna join each of the lightning panelists at a table. So if you guys could, while we're kind of inviting our community partners up here, just kind of spread out amongst the tables. And then, but everybody else can stay where they are. But after that, we're gonna ask you to find the group that you're most interested in. So our community partners are Sarah Dauber here, who is the Executive Director for the Institute for Community Health. Kareem King, welcome, Kareem. Kareem is the Community Engagement Director for We Got Us. And Kayla Kelly is going to be coming in directly from the field and will be joining us in a few minutes. So I'm going to invite Kareem to kick us off. Kareem, if you want to use the podium here, you can. If you want to stay there, the choice is yours.
Hello, everyone. Can you hear me? Great. So my name is Kareem King. I am the Communication Director of We Got Us. Essentially, We Got Us was founded in January 2021. We are a completely Black-run nonprofit based in Boston, focusing on the Roxbury, Dorchester, Mattapan neighborhoods. And we were started because we saw a need in our communities to basically have people like us giving out messaging around COVID-19 and the vaccine. We saw very early on with the pandemic that a lot of the information that was out there was very confusing for people, coming from multiple directions. So coming from the CDC, from the state level, from their own individual networks. And it all got very confusing when it came to knowing who to turn to for this information. So essentially we were found to kind of become that one-stop shop for people, and also to have those important conversations when it comes to what people's fears are, what concerns they have, how we can make this a space for Black people in the medical institution. And over the last year, we built out programs to basically address that issue. So we offer both in-person and virtual experiences. So as a community director, I'm in charge of our in-person aspects, where we do canvassing in the community to basically give out COVID-19 information. We also give out resources at different community events, so farmers markets, block parties, other community things that are put on, things like masks, PPE, as well as other resources that we can basically like source from other different community partners. So in the winter, we work with the homeless, basically give out things like scarves, gloves, anything we can really like basically give out to help our community. And then on the virtual side, we have social media where we basically post weekly updates on COVID-19 information, as well as other important health topics for people. And we offer 1 hour virtual empowerment sessions to have more in-depth conversations about COVID-19 and the vaccine. That's a little bit about us. Yes, I'll pass it.
Great. Hi, I'm Sarah Dauber. I'm the Executive Director of the Institute for Community Health. You may have seen our logo during Dan's presentation. We partnered with BPHC to collect some of the data that he presented on for the BOLT study. I am, as the Executive Director, I'm also a researcher and evaluator. And what we do at the Institute for Community Health is really bridge some of the academic research and the programs who implement solutions to some of the problems that you heard about today. One thing that really struck me with the lightning panel presentations is the potential, we see this a lot in our work as well, the potential for overlap in populations who are experiencing multiple of these problems that you heard about today, and the cumulative effect of that on people's lives. We at ICH, we really believe in a very holistic approach to community health, and it's not just physical health or mental health or behavioral health, but it's also the health of people's social networks, the health of people's families, the health of people's connections to the workforce and ability to live happily and fulfilling lives. And so I think what we see in using public health data for equity is understanding how all of these different issues that face our communities are connected, how we can help provide information that really helps all of us, policymakers, programs, researchers, evaluators, academics, understand how best to serve communities in the ways that they would like to be served also, and really take a more collective and participatory approach to understanding health and improving community health.
Thanks, Sarah. I think when Kayla comes, we're going to ask her, we'll interrupt everybody at that point and ask her to kind of tell us a little bit more about her work. She's a program director at Fields Corner, Crossroads Collaborative, and the House Health, and she's coming in from the field. with fresh information. So at this point, we're going to invite you to join the lightning round presenters and some of the community partners at tables. And we really want to hear and have you brainstorm about, how can we bridge this gap? But before we do that, I just wanted to touch base with our community participants here and ask them, Kareem, Sarah, like what kind of, what has caught your attention today? And is there, if you wanted this brain trust to focus on anything here, what would you like them to think about at one of these tables here?
Yeah, so I think one of the main things that caught my attention today, kind of going back to our theme of our presentation, evidence to basically produce health equity. I think one of the biggest things that we can do as researchers and policymakers is making sure that data is accessible to communities of color and other people who have been marginalized in the institution. People really can use this information to inform change in their own communities and finding ways to make sure that research is actually beneficial to those communities. Thinking about what Dr. Yarbrough did a bit earlier on her work with HAWK and I think BLC, the way they're basically working with community partners directly to do their research and actually using that data to inform their programs and improve them for like future participants. So I think finding ways to do that is really critical to basically using research to address health equity and also to increasing community partnership with these different institutions who have traditionally been separated historically.
And I completely co-sign everything that Kareem just said. And I guess I would add to that just thinking about when we think about programs and the ways that programs interact with the community, trust what they are telling us as researchers and finding ways to build that trust, understanding that health equity and health outcomes look different for everybody, and everybody defines a healthy life differently, and understanding that. I think particularly in public health, we tend to have an idea of what is right for health. What if only, this is something over 25 years I've heard a lot, if only we tell people what is healthy and good, then they'll do it, and understanding that not everybody really has the same definition and that there's a lot of paternalism built into public health, I think is important to collecting better data and collecting data that centers the voices of people in communities and not a paternalistic assumption of what public health should be and what it should look like.
Wonderful, Sarah. So, Sarah, I'm going to invite you to be at this table and lead a discussion on building trust and personalizing health equity measures. And anybody who's interested in that is welcome to join Sarah here. And is there a lightning panelist that would like to kind of support Sarah on that here?
I think she's here.
Oh, Kayla, are you here?
Yeah, she's coming up those stairs right now.
Wonderful. Yeah. Well, while she's coming, we'll keep organizing because we're running out of time. So this is going to be the building trust and personalizing health equity table. And Kareem, I was wondering if you would lead a discussion group. Maybe you could grab that table there. And basically building on this question that you asked about how can we share data and produce evidence to actually have an impact on health equity. So that would be that table over there. And I'm going to invite Michael, who I met just now, who's really passionate about how to communicate data to communities to join Kareem and maybe help lead that discussion there. And Kayla, welcome. So Kayla is, why don't you come over here, Kayla? You're gonna jump right in. So Kayla's coming straight from the field. And tell us a little bit about your work at the Fields Corner Crossroads Collaborative.
Hi everyone, I'm Kayla Kelly. I'm the Fields Corner Crossroads Collective project director. We're a 3-year Children's Health Equity by Boston Children's Hospital grant funded project. We do a lot of work in the Fields Corner community in Worcester around supporting families with housing, economic, civic justice, and food justice work. Specifically, a lot of our work has been focused around offering language capacity in Vietnamese, Spanish, and Cambodian Creole for the vaccine and making sure that families have access to the vaccine and people to ask questions to about the vaccine. Sorry, I'm a little out of breath.
Yeah, thank you. You're like coming right from the field. So I'm gonna ask you, Kelly, you're gonna leave your table here. And Danielle, I think you have a nice overlap in terms of immigrants and access. And I'm with Danielle, is a professor here, and I'm gonna ask Danielle to come up, and your group is gonna discuss how to improve access to the immigrant community for health and education. So we have these three panels here, and Tiana, do you want to have do you have a topic that you want to address?
I think that just taking any one of those and having them do that, especially around the data sharing, I think Kathryn kind of share data, what is how to be defined data, what is happening with it.
Perfect. So this is going to be another data table about how we can do a better job at sharing data and bringing data to the community. And Colleen, how about, what would you like to do? I think obviously preterm births is a critical problem in our communities. Would you like to have a think tank over here with this brain trust that we have? Anything in specific that you want to work on?
I'm open, flexible.
Okay, yeah. I think it's a tough challenge, and so this is our, how can we make a difference for improving I guess reducing preterm births. Thank you. All right, so please, I invite you to join the table for a topic that you're interested in. If you're not interested in any of the topics, come talk to me and we'll come up with something. And what we're gonna do, there's a whiteboard. Please nominate somebody to just make notes, and then we're gonna have readouts. And honestly, if you come up with something innovative, we'll all share in the package. And we'll all use it to make it good.
Yeah, exactly. So the people who are in the virtual attendance, you guys should form a group and discuss one of the questions. That's what I was asked. Yeah, so
is it possible for you to list out the themes, or we can just kind of?
It's okay.
So she asked if it's possible to list out the themes. So
Yeah.
so I can just write themes on.
If not, we can probably figure it out.
Building trust and personalizing health equity.
Oh man.
Thing two is how to bring data to the community in a way that's helpful and useful for them. Theme three is how to generate evidence to produce health equity. Theme four is how to address issues of immigrant health. And then the last theme is preterm birth, how to address issues, how to reduce the preterm birth rate. And ask Sunday Taylor to lead the discussion.
Yeah, and Sunday, can you please lead the discussion?
Sure, that's great.
Yeah, tell her that's a request from Dr. Hall.
That's a request from Dr. Hall.
I got it. Thank you so much.
No problem.
Hi, Teresa.
Hi, how are you?
I work at BPHC. My name's called out.
Nice to meet you.
All other participants, if you don't want to come on camera, that's fine, because this is being recorded, but I'd love for you to just mention your name and kind of share with us what's intriguing for you to discuss.
I guess I'll start since I'm here first. I'm really interested in looking at the issue of trust and how that can better empower our different research projects.
Okay. So give your name and then kind of feedback on which thing could be great to focus on. It'd be great to focus on all of them. Time is always never long enough.
Hi, I can go next. My name is Ashley Scott. I'm working at the BU School of Public Health right now, and I'm interested over COVID. I was working with 4 immigrant communities for vaccine access. We're looking at applying for a grant coming up and looking how to translate data and get the community involved. So I'm interested in theme 4, the immigrant health, and also theme 2.
Okay. Sarah, Andrew, Nayab, or Sarah?
Yeah, sure. My name's Sarah. I work at the Boston Public Health Commission, and I'm particularly interested also in theme 1 of building trust and personalizing health equity, and also theme 2, how to bring data to the community in useful and helpful ways.
Nayab?
Hi, everyone. My name is Nayab, and I'm interested in theme 4, how to address issues of immigrant health, and theme 5, preterm birth reduction.
Sarah S. Helen?
The darn mute problem. Hi, I'm Sarah Helen Ionian, and I work at the Boston Public Health Commission, and I'm interested in immigrant health, seeing as I grew up here as an immigrant in this country, and I know it on a personal level, and I'd like to see it from the public health view.
Andrew?
Hi there. I'm at BPHC in surveillance also. I think generally public health can be a bit siloed, and I'm interested in learning about whatever people feel is most pressing, and thinking about how that affects the data we collect in surveillance.
Okay. And did anyone not get a chance to go? So it looks like we have an interest in 1, 2, and 4, and that's great. I think for theme 1, building trust and personalizing health equity, really converges great with theme 4, which is, it was 1, 2, and 4. How to address the issues of immigrant health. I feel, and maybe I'm wrong, but I think developing trust is a key to reaching out to immigrant communities. And also I think personalizing health equity, part of that personalizing is getting, there's different levels of personalization, and there's having people see things apply to themselves. It's probably the beginning level of personalization. So I wonder if that could be something we could talk about, and maybe we could discuss what are some of the challenges, both we can talk about it theoretically or how we form that challenge in our mind, how we see the problem. We could talk about actual experiences with it, and we can talk about ideas we have, or we can talk about potential solutions that we kind of can't figure out, but think would help. And anyone can start. And theme 2 is naturally involved because in order to build trust and then to personalize, you'd have to be able to bring the data to the community in useful ways. And I think what is useful data differs by individual, but also differs by culture and in your origins and what you're used to, what's important and salient. So I think nice set of questions. Well, I'll start. For me, one of the things I think is striking, and I'm not sure of the solution to it, but I've been at the commission for a couple of years, and one of the things we notice is that a lot of our surveys and data collection are really doesn't do a real good job of collecting, and I think this is mostly survey data, surveys from Asian populations. And I know that there was at least one approach that was taken that actually was really useful in getting larger numbers to participate, in wondering about the feasibility and the usefulness of that approach. So instead of just having the phone calls happen, having the phone calls, they actually went out and did a neighborhood, a geographic based door-to-door knocking and selecting and talking to people face-to-face, and that helped. But I also often wonder about we're used to surveys in this country. I think I've seen a survey probably since I was 8 or 9. But what about how we collect data in how it falls on, meaning not fall on hurt, but how is it perceived? Like, is the intention of data collection something that translates to every culture in any meaningful way? And what do we need to do to kind of make sure that isn't a barrier? I would think even in the subcultures in the US, I know African Americans are often like, I don't want people in my business, or they're going to use this data to some African American groups can say that they're going to use this data to cause harm.
Just a quick time to check in. I'm having some amazing conversations. 10 more minutes.
Oh, I have a comment on that, I guess. I'm trying to mute there we go. So I think my perspective is probably different from the rest of this group because I work in a really small organization. It's a nonprofit. So when we survey our various populations, I think it's more about the immediacy of what we're going to do with that information. Like, are we going back to that person and saying, this is how your information helped us. This is what you'll get from actually doing it. Like, have them be invested in why we're asking questions. And what I've seen in my role, and I've only been with my organization for about 1.5 years, is we've done surveys in the past. We collect all this data and then the administration talks about it, but no one reaches back to the folks who submit the information and say, thank you for answering our questions. These are the types of things that you and your fellow survey takers have said, and this is why it matters. And this is what we want to do and use with your data for. So I hope that's not completely off what other folks are thinking, but that's my experience in a small organization.
I'm going to give a brief comment. Actually, I don't think you're far apart from all of us. I think that is something, at least in the commission, we need to be able to do more in a more meaningful way. I don't know if other people have comments or other ideas of things they've done or that needs to happen, or even operationalizing this or something like that. Like, what are some of the reasons why we have challenges in connecting data to communities, whether it's an immigrant community or other communities that sit on the other on less privileged end of equity? What are the barriers, and what are some of the ways we have been successful at addressing that? And what are the challenges we face? And what would benefit us? What would benefit us to benefit the public health in the ways we think about or do this work?
I'm just thinking about how, like from a more theoretical standpoint, and hopefully a realistic standpoint at some point, would be to integrate the input from the community kind of from an earlier stage, at least from a surveillance process. Thinking about the data that we collect and why we're collecting it, that should be kind of natively integrated into the needs and wants of the community. And if anybody has like a real life experience about how they've done that, I would love to hear that.
But Andrew, could you give us an example of how that comes up as a challenge, or even a fantasy example of how it could work?
Sure. I think when we have situations, we have data that we collect, and maybe kind of in our ivory institutions, we have a way of looking at that data and saying, well, this is what your problem is here. And you go back to the community and you say, well, hey, you have a problem here. And the community's like, well, actually, the problem looks like this. But we haven't collected any information about what that problem looks like to them from their perspective. So I guess building a more holistic surveillance or data capturing system is what I have in my mind, what I'm thinking of.
More holistic, or even more the agenda around what data is going to help answer the question becomes informed by the community or even driven more?
Yes, absolutely. That's a much better way to say it. Yeah.
Any ideas, thoughts, responses from anyone else? Or we can move on to another question or another theme within.
Yeah, I think one of my questions in thinking about how to sort of report and have that transparency with the community is, how is this data important to the community? What are they perceiving when we tell them, that's a problem there, is we're telling them what we found, and then how do we collaborate more and know what they want, how they're going to interpret that data? I think that's something that we're thinking about in some of my work with some immigrant groups is what they need, what their perceived needs are compared to what the researchers' needs are. Are they lining up? Are they different? And how can we sort of stop the siloing between the community-based organizations that we work with every day and, you know, the research groups, and sort of have that bridge?
That sounds fabulous. Teresa, I'm going to ask if you have any examples in any of the projects. You're with ICH, Teresa? What organization are you with?
Oh, I'm sorry. I'm with the Guild for Human Services.
Okay, so I'm not familiar with the work, but have you guys been able to be successful at shaping a co-created or an agenda that reflects at both, or at minimum, the community, particularly if we're talking about immigrant communities, agendas when it comes to data research and the rest?
Hopefully I can say yes to that in about 3 months.
Tell us.
Well, we're actually in the process of designing a survey that we'll be sending out to our DSPs that work with residential staffing in community care-based homes for intellectually disabled children. And the significant portion of our DSPs are immigrant staff. And we haven't sent out a survey in over 2 years. Actually, I think it's been 3. COVID in part, and this would be the first time that I'll be sending it out. But when I guess I'm trying to get some ideas from you guys today, because I'm looking at the survey that we sent out 3 years ago prior to my time. And these people are saying, this is really upsetting me. This is really important. Why can't we do this? And so far, it looks like no one ever addressed those questions. They collected the answers, but they never responded. And so one of the things I'm tasked with doing is trying to design a way that I can give that feedback to these several hundred DSPs that we have on staff that I anticipate will probably have many of the same concerns.
Mm-hmm. So one of the things I think you highlighted was that, what does it mean? There's one thing to say, we want your input and we want to know what you want, but if you do nothing once they tell them, it becomes, research becomes useless or useless to them. And so the intensity with which it gets participated in and absorbed and used is, we're back now. Or does anyone else have anything to say? I think we're given.
Sorry, we're wrapping up right now. So if anyone has any last thing to say, do you guys mind writing like something in the chat or something? You guys have something else to say? Sorry, y'all. It was such an interesting conversation. I didn't want to end it.
Yeah. Hold on. So really, what it.
All right, everybody, number one, is going to do the readout and tell us about your topic, generally who's at your table, and what you found.
We have a little bit of everything at our table. Community health workers, graduates, brand new employee of Monday. But we were focusing on reducing disparities in vaccine access. And so a big part of what we were talking about is language, accessibility, and then also incentives. And that really we're able to get more families out into the community. Making sure that there were trusted messengers. So I work at Rochester House Health Center. We're already kind of well established in the community, and nobody had there was much more trust in coming to receive a vaccine from us, especially knowing that there was somebody with your language and cultural capacity to talk to you there to get the vaccine. And then also offering incentives like food, music, PPE, gifts. We partner with, sorry everybody, We Got Us, and we offer that once a week. We offer a vaccination clinic with a mobile vaccine clinic and testing clinic there.
but also finding ways to offer incentive like $25 gift cards, whatever families really need to make sure that there's a wraparound service and they can come in and it's not a waste of their time to come in. Offering community spaces like we work at the News, the Community Health Center, offering media and information in multiple languages, offering wraparound services, having personnel representatives in the community, making sure that IODs are not required, like you don't need a driver's license, you don't need a health card, verifying that health insurance status is not required to receive a vaccine, and making sure that there's testing availability or, again, some other wraparound service. Was that 3 minutes? Did I speak fast enough?
Lightning speed.
That was amazing, Tara. And I think what's interesting is it kind of echoed Danielle's theme of inclusivity versus exclusivity as the way to kind of have an intervention. Thank you so much. All right, here we go. Table number 2.
Thanks. I think we at our table talked about some similar things in terms of trust building. We talked about having established meaningful partnerships with trusted people in the community, and what that means for institutions like the Boston Public Health Commission, that is a trusted institution in many ways, and how developing those partnerships before a crisis is really important, so that when there is a crisis like COVID, that there are already established institutions that can be those trusted messengers. But we also, as people who all have experience as outsiders coming into communities, trying to do work, whether it's research or community planning or public health intervention, talked a little bit about listening. The challenges in agreeing on problem definition and who gets to decide what a problem is, and who are the community members. Is it just a group of people who have kind of the loudest voices, or is it some other sort of meaningful representation of the community, however you define it? We talked about when there are issues of problem definition, understanding that sometimes people in the community aren't necessarily willing to talk about some of the biggest problems and instead want to focus on what seems possible in that particular instance and what that means for people who are coming into communities, and trying to do research and collect data, and that oftentimes there's data collection fatigue and people want to hear about solutions and not necessarily absorb more data, and the importance of kind of wading through that data and presenting data that are meaningful and are kind of goal-oriented or solution-oriented. I think that's about everything we talked about. I don't know if I missed anything, feel free to jump in.
Fantastic. So we're building on inclusivity versus exclusivity with incorporating the community early listening, and also I guess that a little bit of an inclusivity theme as well. Wonderful. So that's about how to get to the right data, and now we're going to talk to the data people right here.
Hello, everyone. So I definitely agree with everyone's position that was said at the three tables. And I will say that we had very similar conversations at our table when it came to talking about data, how it can be used to empower communities. So I think the 3 big things that we kind of focused on is like using data to empower when it comes to education, advocacy, and contextualizing data for the population we're talking about. So the first aspect we want to get to is education. So understanding the importance of having those like numbers and that data in the frame of mind, so you understand like what the actual issue is and why it's so important that we have a stake in this issue. But it also is important to make sure that we're understanding the individual environment people come from, and knowing how to contextualize this data so that they understand the importance of it and why we're actually telling them this in the first place. And then going along those lines, also talking about how we're giving out the data and where we're giving out the data. So the importance of place is very important to talk about, especially when it comes to who this data is important to and what we're actually trying to like accomplish with this data that we're getting. So speaking to my own personal experience working with BGS, we're mainly focused on providing for the health needs of Black and brown people. So we're going to papers that basically like house those people. So going to Dorchester, Mattapan, and Roxbury, and using the data that we saw early on when it came to who was under vaccinated in those different neighborhoods, basically pinpoint our outreach and work with those and establish places that they seem like make sure that happens. Another point that we talked about is advocacy. So the importance of using that data to talk to local and state level officials about what the needs are of community members and essentially translating that so that they can actually have sustainable change when it comes to like budget improvements in ways that we're actually talking about communities and improving improvements that they have. And then the third thing we talked about is, as I said, contextualizing data, understanding like where the common ground is, and we're kind of talking to community members. So really, so Jonathan, with the Museum of Science, we talked about the importance of basically like pulling in community members and finding that common ground when it comes to what we're actually talking about in this instance. When it comes to data, how it's important to people and how we're actually using it to improve their lives. What are we actually doing that is basically make it so that it's accessible to them, that it's useful for them. Those are the main things we talked about. I don't know if you guys want to add anything else, but really good conversation. Yeah, data analysts, yeah, some Museum of Science, also the content creator here, as well as some of which democratizing science. So it's really good. Thank you.
Amazing, thanks, Greg. Very inspirational. So now we're gonna move to preterm birth. And who's gonna?
Good afternoon, everyone. I'm going to name everyone that's in this group. David, Bailey, Collette, and my name is Farai. I do want to say we didn't focus specifically on preterm. Collette opened it up to just say, you know, what questions might you have, what might be resonating or kind of coming up for us. And Bailey asked a very wonderful question that was around, okay, we've collected all of this data, we have the data. She's at Harvard working on a project. How do you translate that into actually changing the way someone thinks about it, right? So then we started to have a deeper dive in this idea of systems and changing the systems. We know that there's a systemic issue that's going on, but there are individuals that make up those systems, or individuals that are making decisions about those systems and perpetuating the systems or going against the systems. So then we started talking about, well, how does change happen at the ideological level? Because we say, we want to do some change, we want to use this data to change people's thinking so that it translates into their being and their actions. And so then I started to share some about my work, which is in the body of somatics, which is how you align actually someone's thinking, what they care mostly about with what the actions that they're taking. So we started talking a little bit about thinking beyond the technicalities. There are some technical things that we want to change, which is in the system sphere, but there are these adaptive things that also need to change in order for those technical things, which data, for instance, or data research would support. So we just had a really rich conversation about, you know, is it individuals? Is it the interpersonal relationship? Because we also, if you apply this racial equity lens to it, right, we're looking at racism and how it might affect whether it's preterm births or any other of the outcomes. How do you shift people's way of thinking about things so that they can actually change their actions? And for me, I started to share with them that in the world of somatics, we shift out of this Cartesian way, which is that, you know, the brain is where all of the intellect happens, but we marry the brain back into the body in which it is housed, right? And that there's all of this information that happens in the body, and what you really want, but in our humble opinion, to be focusing on is reconnecting people to their senses, to their feeling, to that feeling nature. This is how we shift. And then we started to have a conversation about ethos and values and mental frames, having kind of a sense of making sure we're on the same page with that and how important it is. Before you can do any changing, you have to make sure that people have a shared understanding of the mental frame or the languages that they're using so that we can also move in that direction. So we're talking about not just the data itself, but then how do you get the data to become activated in people? I use the example, like if you just give people information, hence data, smoking is bad for you, so just say no, right? That doesn't change how people actually behave. So that is the rich conversation that we had here. Did I miss anything, team?
Thank you. I really think that was really, I mean, powerful to go from, data, which is such a cognitive process. And, we're gathering data and measuring people and forgetting that it's the people who have the bodies and the experience, and how do we bring that data and translate it back in a way that they can incorporate it. And I love this somatization. That is beautiful. Thank you so much. There we go.
So our table discussed, similar to some other tables, basically of getting data from, with, and then returning the data in a meaningful way, like to a community. We are researchers, program evaluators, executive directors, and government task forcers. But so our comments echo a lot of what's been said. We discussed really seeking the questions and the answers from the community. What do they want to know? How do they define the data? What are they interested in learning? And what do they have the capacity for? I think is kind of a real world consideration. Asking questions up front, but also having ongoing conversations, being really transparent through the whole process about why are we collecting this data? What is the data being used for? How does this benefit you or not, or maybe in the future might, how it might benefit the community. With really relying on the expertise of the community, but at the same time having to do some initial research ahead of time, so people you're not duplicating work that other folks have already done. Like that is a way to build trust, but also not be duplicated. Making sure everybody is on board, finding the stakeholders again, and then engaging the community about, kind of aside from the data, like what does the community think are the solutions to the problems that they identify? Sometimes there are challenges of partnerships. There's a great example. Okay. If in a situation where there's like different types of stakeholders, like law enforcement and like a survivors kind of a group, that the focuses of those partnerships are really different, and therefore sometimes data are not counted or they're counted twice. So, having a partnership where you're kind of on the same page is very important. And then, how do you collect data from vulnerable and marginalized groups? Ethics considerations and mechanics around all that. Again, just, building trust.
Such a thoughtful outline. And so, because this is 2022, we have to have the Zoom group here. So here we go.
Yeah, so I was talking to the Zoom group, and essentially we were talking about how some of these themes were actually related to each other. And so we were talking about how the first theme was related to the fourth theme. So we were talking about personalizing health equity and how using personalized equity, you can address some of the issues for the immigrant health problem. And so one of the things we were talking about was what it meant not to be siloed and working in collaboration together, having less one-sided engagement and more sort of like full circle collaboration and communication at each level. And then, so letting people know what the purpose of the research is, so that basically there's not that gap between like the community and like the researchers who are doing research about it. And we need to do a better job acting on the results and sharing the results back along with anything that happens or changes because of the results. And then lastly, we talked about how we can ensure that the communities are involved earlier in the process so that like they don't feel like they're being like surveilled rather than like, you know, being helped, right? So that's kind of there's a little bit more about, I can't, scrolling too fast. Yeah, scrolling too fast. But basically it's saying the people who live in the community are more concerned about the disequity than the researchers, if that makes sense. Yeah.
Great. Well, thank you so much. Thank you everyone for participating and I think really a very novel experience. I'd like to invite anybody who has any feedback real time on how we could have made this session better or what was really good about it or helpful about it. If you want to just jump in now, we have like a few more minutes as we wrap up. If not, calling once, twice. Here we go.
I would have loved to have a chance to talk to the rapid fire panelists, just ask a question.
Yeah, why don't you do it right now?
I'm going to after the fact. I've got so many questions now.
Okay, you don't want to do one? We have time for one. Okay, all right. Carpe diem. Anyone else? All right, well, thank you for that. Yes, we'll try and incorporate that. Kelly, did you say something?
Yeah, I was just gonna say, it might be really cool to put the questions up on the wall so that everybody kind of gets a chance to look at the same questions and think about them, to see if that opens up any deeper thoughts.
Thank you so much. All right, well, that's it. Thank you for joining us.